Ladies and gentlemen, we now commence Symposium 19, focusing on nephrology, with updates on vasculitis, lupus nephritis, and hepatorenal syndrome. I am delighted to invite our chairpersons, Professor Rezvi and Professor Kamani Wanigasuriya, on stage. May I now invite our chairpersons to introduce the speakers and panelists for this session.
It's my greatest pleasure to invite all of you today. The first speaker in this nephrology symposium is going to be none other than Professor Mumtaz Patel. You have already heard her at the inauguration. Professor Mumtaz Patel is the president of the Royal College of Physicians, London at the moment. And she's also a consultant nephrologist at the Manchester University Hospitals NHS Foundation Trust and the Honorary Clinical Professor at the University of Liverpool. Elected in 2025, she is the first woman of South Asian heritage to lead the Royal College of Physicians, London, in its 500-year history. So she's a specifically remarkable lady. She's a graduate of the University of Manchester. She qualified in 1996, completed a PhD in the genetics of lupus nephritis in 2006, and was appointed consultant in 2007 with a master's in medical education. She has established a national reputation in postgraduate education, assessment, and training. She has served as the Royal College of Physicians Senior Censor, the Vice President of Education and Training, and a Global Vice President leading initiatives in education strategy, global engagement, and in women's leadership. She has also held senior NHS and university roles, combining clinical expertise with medical education and leadership. The topic that she has chosen for today's symposium is vasculitis and the kidney, an overview. Over to you, Mumtaz.
Oh, bless you. Thank you so much for the very kind introduction. It always feels like family when I come back to speak here in Sri Lanka. So thank you so much for having me. So as you rightly said, with the Nephrology Symposium, I was asked to talk about vasculitis and the kidney. In the UK, in the northwest of England, which is where I'm based in Manchester, I run the Vasculitis and Lupus service, having had the research expertise around both vasculitis and lupus. So what I'm hoping to cover in the next 20 minutes or so, firstly, no conflicts of interest to declare, and what I'm hoping to cover is some of the kind of broader overview. 20-25 minutes is hardly enough time to go through the detail of vasculitides, but I'll give you a bit of an overview around the definitions, some of the categories and clinical presentations around around vasculitis and the kidney, the epidemiology broadly speaking, and then I've got 3 cases to illustrate some of the diagnostic and management challenges. I think day to day, since I was a resident doctor, a junior doctor, one of the main challenges was, how do you pick it up early enough to make a difference? And then all the different management challenges that go with it, particularly with the balance between the complications of the treatment as well as the treatment itself being a success. So I'll, kind of go through some case studies to illustrate that. And then the indications and timing of a renal biopsy, which is very important and remains the gold standard for the diagnosis. A little around pathogenesis and the role of ANCA, and then more around an approach of management. There's so many clinical trials, and this is a very research active area, and I certainly don't aim to cover every single trial there is, but just to give you an approach and my experience around managing difficult cases, and a short mention around treatment outcomes. So vasculitis, as far as definitions are concerned, so whenever I'm doing this as a teaching exercise for our medical students, the vasculitis per se is inflammation of the blood vessels. It's very much a heterogeneous group of diseases characterized by inflammation, necrosis, and then it's the damage to the blood vessels and the occlusion of the blood vessels which causes the end organ damage. It can affect any type of blood vessels, any size, location of blood vessels may be involved, and it could be primary or secondary, and then there's certain mimics around vascular disease that I'll talk about as well. And it could be confined to a single organ, such as the skin or so, but the ones that I see in nephrology, and I'm sure many of you have seen, are the ones that affect multiple organs. I'm sure many of you are aware of the Chapel Hill consensus framework, and that kind of gives you that overview of categories. And the classification is very much based on the size of the blood vessel affected, and the ones that we see are much more of the small vessel vasculitides, but I do have some patients who have large vessel vasculitis, which is predominantly around Takayasu's arthritis and giant cell arthritis. The medium vessel ones, I do have some patients in clinic with those as well, with polyarthritis and nodosa Kawasaki's disease as examples. And then the smaller vessel ones are the ones that we see majority-wise in our renal clinics in particular, which could be the immune complex vasculitides or the anchor-associated small vasculitides, which is predominantly what you associate vasculitis with in our renal clinics. And then, of course, you've got anti-GBM disease as well. And patients with, the immune complex types could have cryoglobulinemia. One of my patients who I just see last week had cryoglobulemic vasculitides as well. And then IgA vasculitides. And then the treatment pathways for each of these are slightly different as well, which I'll give you an overview on as I go through the cases. So clinical manifestations-wise, again, as I mentioned, it's a multi-system autoimmune condition. It predominantly affects older age male group. We are diagnosing more patients now. It was probably less diagnosed in a tertiary center like mine. We see it a lot in my clinics. When I have medical students or junior doctors sitting in my clinics, they'll say, gosh, every other patient is vasculitis. But then I do run the service, so I see much more. But in an average GP center in the community, they may see 1 or 2 cases in their entire career. So it's not that common, and I'll go through the incidence and prevalence shortly. So it's multifactorial in etiology, widespread clinical manifestations, as you can see, and many times patients present with these non-specific constitutional symptoms, which they may have for many years before their actual diagnosis happens. And that could be just flu-like symptoms, feeling tired, malaise, arthralgia, rashes, and, the diagnosis comes sometimes very much later than the initial presentation. And as you can see, the ones that we see may have the classical chest and renal syndromes, but then ENT involvement is quite common with certain types of vasculitides as well. As far as investigations are concerned, like anything, when I'm doing my teaching, you've got your non-invasive investigations and then your invasive investigations. The invasive investigations, like the biopsies, still remain gold standard, but then there's many other investigations you can do now. So MRI scans on the right-hand side showing granuloma of one of my patients who presented with ocular vasculitis, which was quite life-threatening from an eyesight perspective as well. And then the second is just a plain chest x-ray, but then you have CTs and further scans that you can do, and that shows the nodular lesions for a patient with vasculitis affecting the lungs. And then the renal biopsy findings. So the renal biopsy findings, very much the crescentic change that we talk about, which is lots and lots of activity of macrophages, which can affect the glomerular space. And it's the occlusion of the glomerular space, which then causes the acute kidney injury. And that causes that clinical syndrome of rapidly progressive glomerulonephritis, which leads to the acute kidney injury. And then on the far right-hand side, side, you've got the rashes, which are quite pathognomonic of vasculitis as well, that we see in many of our patients as well. So lots of different ways, blood parameters, urine parameters, and then your non-invasive imaging, but then your biopsies which are gold standard. You have PET scans as well now, which we look for activity around, particularly when it's multi-system disease. So then the further classifications between primary and secondary vascular disease. So the primary ones, which I've covered when I showed you the previous illustration as well. And then the secondary ones, particularly for lupus. So given I do a lot of lupus patients as well, I have a number of lupus patients, who then develop vasculitis or class 4, which I'll talk about, different classes of lupus vascular disease as well. And then infections, we see less of this now, but I do have some patients with Hep B, C, and HIV, patients who've then developed a secondary vascular disease, and then medications, malignancy, lymphomas, leukemias. And then the mimics on the right-hand side that you can see, I had a patient recently with substance abuse with cocaine who had, kind of nose damage and collapse, and then presented very much with acute kidney injury and looked as though he may have underlying vascular disease, but actually it was all cocaine abuse-related renal disease rather than pure vascular disease as well. So there's other things that mimic as well. So keeping an open mind in that sense is important. And then immunosuppressing those patients, you're going to make things worse. So I think just making sure that you've excluded some of these mimics as well before you start treatment. When you look at the epidemiology of ANCA-associated vasculitides, they vary very much by different continents, but also latitude difference as well. So you've got a predominance of GPA, the granulomatous polyangiitis in Europe, and certainly north sort of side of things. And then in Asia, there's a predominance of microscopic polyangiitis, particularly in Asia. And then their phenotypic as well as genetic factors are very much different, both in presentation, but also then how we manage these patients as well. So I'll go through a couple of cases now just to highlight some of these diagnostic and management challenges. So the first patient is a 54-year-old gentleman, an accountant who was referred to our general medical clinic, presenting with a 2-month history of general malaise and polyarthralgia. He had a 2-week history of shortness of breath, fever, and then more recently palpitations, having recently been away on a holiday in Mallorca, which is in Spain. And then on examination, he was pyrexial, a low-grade temperature, with some splinter hemorrhages noted and a pansystolic murmur, which was thought to be new. And on urine dipstick, he was found to have hematoproteinuria with blood and protein. And I guess, kind of if I do this as a teaching activity, I'd sort of say, how's the diagnosis? And I'll get people to put their hand up. But looking at that presentation with the kind of prodromal symptoms, but then more recently as a new murmur, and a temperature and a splinter hemorrhage. The working diagnosis for this gentleman ended up being subacute bacterial endocarditis. And then the management, he was started on IV antibiotics. His transthoracic echo showed a mild MR and maybe a suspicious mass in his posterior leaflet of his mitral valve. However, he continued to spike temperatures despite the antibiotics, and his renal function continued to rise. And as you know, as nephrologists, with the gentamicin and the levels, and always difficult to measure and assess, but his renal function started to go off. His gentamicin levels were high and that were adjusted, but despite that, his renal function continued to worsen. Subsequent blood cultures were negative, and a transthoracic echo, following that, the transesophageal echo, which took a week to arrange, then showed no vegetations. By this time, the renal team got involved and we came along, and hindsight, as I say, is always a wonderful thing. And an exploration of the history further, epistaxis was noted, ear aches, nasal crusting, and multiple nail bed infarcts. So now the diagnosis was potentially different, given that he was treated for a week with endocarditis without any improvement. So now the clinical diagnosis changed to systemic vasculitis, and his antibiotics were stopped. He had an ENT review which excluded acute infection. He had normal-sized kidneys on ultrasound scan, and then went on to have his immunology checked, which was strongly positive, with C-ANCA positive and a PR3 of greater than 80. He was given high-dose steroids and a biopsy arranged, and as then expected, the biopsy was very diagnostic to show necrotizing granulomatous lesions, over 50% of cellular crescents, with severe arteritis, fibrinoid necrosis, and a strongly positive C3. So histologically, this diagnosis is porcine immune, necrotizing FSGN. The focal aspect and the segmental aspect. So focal is around less than 50% of involvement. Segmental is one part of the individual glomeruli being affected, and then severe inflammation noted. So he was treated with pulse methylprednisolone, IV cyclophosphamide, and then a lot of other treatment goes in with our patients. So whether it's Septrin for antibacterial prophylaxis, antifungal prophylaxis, lansoprazole for PPI protection, and then he was dialyzed for a short period, plasma exchange given his presentation, and he had a good clinical recovery thereafter. And he became dialysis independent, and his renal function came down to 150. So this highlights the atypical presentation of vasculitis. In general medical clinic, I'm sure you see so many patients with all sorts of presentations, and you don't always pick these patients out. But I guess, there's certain features that subsequently came to light which were diagnostic more for vascular disease. The second patient is a 73-year-old housewife admitted to one of our peripheral hospitals in Manchester with shortness of breath and was diagnosed with a chest infection. Her renal function on presentation showed an acute kidney injury with a creatinine of 334, eGFR of 18, and she was treated with antibiotics. After she improved, she was sent home. Now, the plan was to recheck her kidney function a week after discharge. Now, that didn't happen, and she was readmitted a month later, more breathless, and a chest x-ray was significantly worse. Her renal function was much worse, and she was transferred then to our hospital, where she was oligoanuric, hypoxic, and was transferred from a general medical ward to high dependency and intensive care straight after. She was very hypoxic, fluid overloaded perhaps, or whether this was pulmonary hemorrhage, and she had to be intubated, hemofiltered, and unfortunately she died 4 hours later. And a post-mortem diagnosis was then of Goodpasture's syndrome with lung hemorrhage, focal necrotizing GN, secondary to microscopic polyangiitis, and her immunology from the initial blood tests, which came back after she died, was positive for p-ANCA and MPO of greater than 80. So again, an anti-GBM positive, highlighting the urgency of the management as well. And sometimes, yes, we do get it wrong, but kind of having a lower threshold of doing some of these investigations early. And she fell through the cracks because of, going home, which was fine, but then not perhaps having some of the follow-up investigations which were planned for her. And the last case is a 19-year-old lady who's Caucasian, SLE since age 14, presented with skin and joint involvement. She had a positive double-stranded DNA low complement, treated with hydroxychloroquine. She was then subsequently diagnosed, presented with meningococcal sepsis a few years later after her initial diagnosis. And she was treated for that, improved, and then referred to me a month or so later with persistent hematoproteinuria. She was normotensive, low-grade proteinuria, low level of immunology showing activity perhaps of her lupus, and her renal function at that time was normal. And the question was whether you do a biopsy then or not, and what may it show. So given she's just had a meningococcal sepsis, she could have post-infectious GN, and if that's the case, you don't always biopsy these patients. But then given her history of lupus, she may have lupus nephritis as well. So we observed initially for a few weeks and then brought her back, and the proteinuria started to go up, still not nephrotic range, just about 1 gram, and the renal function was still normal. But when we did the biopsy, she had severe class 4, which is global active changes, proliferative changes of lupus nephritis with crescentic change as well. So basically, kind of very active change despite the clinical presentation not being so severe. So she was treated with, again, high-dose steroids, pulse cyclophosphamide, a Lupus regime. She had improved lupus serology, and then later she was switched over to mycophenolate. She's just recently had a little baby girl, and she's maintained on prednisolone and azathioprine. She flared postnatally after her girl was delivered, and she's now been managed with rituximab. So again, this indicates the clinical presentation doesn't always reflect the biopsy findings, and that's quite typical for lupus in particular. So again, in many of my lupus patients, there's a very low threshold of biopsy. So the timing of the biopsy, the initial biopsy should be performed promptly, kind of in these cases, rapidly, particularly in the first couple of cases, and a delayed diagnosis can cause an increased risk of end-stage renal disease. And many of these patients may need repeat renal biopsies as well to distinguish active versus chronic disease, as well as other features. We had a patient recently who had drug-induced interstitial nephritis rather than underlying vasculitides. The role of anchor that I've hinted on in vasculitides is very important both for the diagnosis as well as the management. And, the presentation for PR3 and MPO is quite different, both from the clinical presentation, the histological findings, as well as the management features as well. And then the pathogenesis and the biologic agents. So there's so many biologic agents now, you can't keep up with the newer ones and newer trials coming in. But certainly for the anchor-associated vasculitides, the B cell and the T cell activity is there. So a lot of our patients are on, sort of rituximab. Eclusumab now is coming in for the eosinophilic, as well as the complement activation with avacopan has shown promising results. And we use that in particularly our refractory patients as well. And then the presentation, this is a busy slide, but basically showing the clinical as well as the diagnostic differences and the management differences between PR3, MPO, vasculitis as well. So the PR3 patients, more predominance of male patients versus female predominance in the MPO patients, the Northern Europe, as I mentioned, together with the Asia ones. And then more importantly, the clinical presentation factors, the granulomatous presentations in the PR3 vasculitis with ear, nose and throat involvement and more multi-system presentation versus more renal limited and lung involvement in the MPO patients as well. Management-wise, you've got the induction phase versus the maintenance phase. The induction phase is between 3 to 6 months, and my practice still would be some steroids, although tapering very quickly, and then the choices between cyclophosphamide or rituximab, and then the maintenance phase after 6 months or so would be azathioprine, methotrexate, depending on lung disease, or mycophenolate thereafter. And then you have many patients with refractory disease, which are quite difficult to manage, and then some of the newer agents are used thereafter in those. I don't aim to cover all the clinical trials, but some of the ones related to rituximab have been quite interesting. So the rituximab has been found to be superior in certain patients against cyclophosphamide, particularly in relapsing disease. So we're using rituximab much more now, and particularly for our younger patients of childbearing age. And then the other trials thereafter around sustained remission, as well as reducing relapse rates as well. The challenges in vasculitis management is very much getting that balance right. So the benefits are there of immunosuppression, of treating the disease, controlling the disease, reducing the relapses rate, but it's the side effects. I mean, the first patient I managed as a consultant was a 70-year-old with vasculitis, and sadly he died of a complication of severe pneumonia with infection following his treatment. And that I really remember that because it's the side effects sometimes which causes the morbidity and mortality and the complications of therapy. So you can't forget that. And all the steroid usage with all the steroid-related side effects, the immunosuppressive sort of effects as well. And then the cancer risk. I've had a number of patients with solid organ tumors later down the line following treatment with vasculitis as well. So addressing comorbidity is important in all of our patients. There's an increased cardiovascular risk for all renal patients, but particularly in vasculitis as well. And treating all of those things are important. So managing their blood pressure, their diabetes, bone protection, lipid reduction, anticoagulation, particularly with those with increased clotting risk, and then antiplatelets and vaccination. That was one of the other learning factors for COVID as well for many of our patients as well. And then the broader lifestyle changes for protecting our kidneys. We talk about being hydrated, a low salt diet, and then the wider cardiovascular risk factor management as well, and avoiding all the nephrotoxic drugs, as we always talk about as well. So in summary, as I've hopefully demonstrated, that vasculitis patients don't always present in a very typical way. So it's having that low threshold of both diagnosis and picking things up, and then a low threshold for investigation and management. You need to consider the underlying causes of vasculitis. Treating those will then help enable the treatment of the vasculitis itself, infection, malignancy, secondary causes, and the mimics as well. And the treatment for vasculitis, like I say, looking at the underlying causes and the timing of the biopsy is important. Tissue diagnosis still remains gold standard, and that earlier diagnosis and starting of treatment, like in anything, improves outcomes. And this challenging and balancing complications of treatment and personalizing therapies, particularly with different presentations, and a lot of my work was around genetic risk as well as then the management aspect side of things as well. So lots of things to consider, and I hope the presentation has been helpful, and I'm just on time, so that's always good. Thank you very much.
Thank you very much, Professor Patel, for that very interesting presentation. Let's move on to the next lecture. It's by Dr. Ravi Rajakariar, who is a consultant nephrologist and clinical director of renal medicine and transplantation at Barts Health and NHS Trust, London. He leads one of the UK's largest renal registries, delivering comprehensive care across northeast London. His clinical expertise spans complex immune-mediated renal diseases, and he also is an active in dialysis and transplantation services. Over to you. And his lecture is on advances in the management of lupus nephritis.
Thank you very much for the generous introduction. My background as a consultant nephrologist at Royal London. My subspecialty interest is lupus, vasculitis, and renal sarcoid. These are my declarations. So I'm just going to run through, I'm not going to talk about lupus as the pathogenesis or the genetics, but I'm going to focus mainly on the treatment options. I have another whole presentation around managing difficult patients, but that again is not permitted on the time restrictions and also your attention span, as I would imagine. So we'll talk around the remission, the guidance, the CNIs, steroids, and anti-CD20s and other biologics. So what about remission? How do you define it? And it's very tight, and it says less than half a gram of protein within 12 months. But the reality is different. It takes up to more than 12 months, often up to 18 months to a year, before you can be convinced that the patients achieve remission or not. Partial response is less than 50%, more than 50% reduction in proteinuria, bringing it less than 3 grams a day. And around 6 to 12 months, if the patients are not achieving partial remission, then you've got to revise your treatment options and consider alternative choices. So what are the current guidance? So this has moved very fast in the past 2 years. ULA was first off the mark, published their guidelines in 2023, and they had a very nice, colorful schema. Then came KDIGO. We nephrologists love to make it very complicated sometimes. So it's a very complicated summary slide. And then ACR just published their guidelines, etc. And as you can imagine, the flavors are slightly different, but the treatment options are pretty much shared in all those 3 guidelines. So what are the common themes? Firstly, all patients should be on hydroxychloroquine. One of the mistakes I even personally have made is not adjusted to weight and renal function. So to get the optimal treatment, you've got to follow guidelines on how to dose hydroxychloroquine. Induction should be with IV methylprednisolone. It's shared in all of the guidelines. Interestingly, the key pivotal paper, the Ginsler study with mycophenolate, which is the standard of treatment, did not have IV methylprednisolone induction, but that is now the accepted guidelines, and in fact, all the newer trials also have IV methylprednisolone as part of the induction regimen. Mycophenolate is the standard of care. All the studies, especially the latest ACR guidelines, are now promoting triple therapy either with calcineurin inhibitor or belimumab. The prednisolone dose should come down to at least 5 milligrams or less at 6 months. Now, what are the caveats? So the steroid tapering regimen isn't very clearly defined. KDIGO gives you 3 different options, and we would need to be guided by some of the newer trials when it comes to steroid tapering. Also, one thing that we personally in our unit also guilty that we are not very good at adhering to tapering, partly because we don't give the clear information to our patients. The role of IV cyclophosphamide seems to have gone slightly out of favor in all the studies, all the newer guidelines. But we do use IV cyclophosphamide quite a lot. And it's very important to appreciate that the Lupus, which gives you a cumulative dose of 3 grams, is not associated with risks to fertility. And this has been based on studies that looked at anti-Müllerian hormone levels, which has shown that, especially in our younger patients under the age of 30, 3 grams is perfectly safe. As always, this is a fast-moving area. There's a lot of nice studies coming out, and the guidelines are already slightly out of date with the publication of the Regency trial this year. It's very important. I look after, just like Mumtaz, I look after vasculitis and lupus. Vasculitis is easy. Lupus is tough. Our patients are difficult for various reasons, and we should consider personalizing immunosuppression. And again, I'm not got the time to cover that in this. So what's our current practice? Our standard practice is we go for prednisolone, hydroxychloroquine, mycophenolate, and in those with preserved renal function, we will add a calcineurin inhibitor, and we've got the option to give voclosporin because it's NICE approved, so it doesn't come out of my drug budget. So I prescribe it, and we all prescribe it to our patients. We do, however, give cyclophosphamide. It's a very effective drug. It's intravenous, 6 doses, in a 12-week period. And we tend to give it to people with aggressive disease, especially when they have significant renal injury, because we are old-fashioned, we know it works, and we know it works fast. Also, in patients where we are having difficulty in controlling the lupus after 6 months to a year, and often it's the case in our practice, it's due to non-adherence. Rituximab is also increasingly coming back into favor. We tend to use it for, with renal lupus, especially those with skin involvement and non-adherence. And belimumab, we do not use it the way the trials have recommended, but we do prescribe it nevertheless. So let's talk about voclosporin, which I appreciate isn't available in the UK, in Sri Lanka. It is effective, and this is a 1-year study which has shown that complete renal response, and that's looking at less than half a gram a day of protein. Patients on voclosporin achieve this far greater, significantly greater than those who are not on voclosporin. But also voclosporin did was have a rapid steroid taper. So you had 2 doses of IV methylprednisolone at the outset, and then your oral steroids started at 20 to 25 milligrams, significantly less than what we have historically done so. So both cohorts got IV methylpred and a rapid steroid taper, and that is your standard steroid taper, rapid steroid taper. And this is really important because we do use it, and we have now got over 18 patients on it, and this is an old slide. We're just completing the audit on the 1-year data, and we found that there was quite a rapid reduction in the proteinuria with the use of voclosporin. However, It's expensive. I think the UK costs something to around 3,000 a year, pounds a year, which is not cheap, and it's not going to be available or affordable for the vast majority of Sri Lankans. Calcineurin inhibitors, though, are available and have been used, and there are limited trial data historically of its use, and it's shown that it's effective. However, you need to monitor drug levels, and the standard most commonly used is the transplant maintenance level, so 4 to 7 tacrolimus or cyclosporin around 100. And it has been shown to be effective in reducing proteinuria. And more importantly, unlike in voclosporin, it's safe in pregnancy. There's no data of voclosporin in pregnancy, and it's not licensed to be used in pregnancy. Again, it's around all CNIs means lots and lots of more tablets. One of my patients who I recently started on Voclo said, I take 30 tablets in the morning and a few more, less, but quite a lot in the evening, and that's a problem. Therapeutic drug monitoring, as I mentioned, and we are increasingly appreciating hypertension is a problem, right? And that we need to not ignore, especially in our young patients, and of course, diabetes. Now, there is a case to be made to reducing the steroid burden, without a doubt. High cumulative dose of steroids do increase the risk of infections, osteoporosis, diabetes, and a problem that is, as previously the whole diabetes talk and around weight gain is a major issue, and you are dealing with young patients. They don't want, their body image is as important as managing their lupus. Steroid-sparing regimens are useful, and there is good data that if you use methylprednisolone at the beginning and use a rapid steroid taper, you will lead to an overall reduction in the cumulative steroid burden. And the dose I would recommend is what's clearly prescribed in the Aurora 2 study, in the voclosporin study is, and this is what rheumatologists have been doing for a long time. We nephrologists have been really behind in coming to the party of reducing our steroid burden. So moving on to the biologics. I used to use rituximab a lot, and I was a big fan, but unfortunately, these trials were negative. Both Explorer and Luna showed that adding rituximab on top of standard of care did not lead to better outcomes in patients with lupus nephritis. I will come to belimumab in a minute, and I will now go to the most exciting thing that's happened this year is obinutuzumab. This is an anti-CD20, and what it did show was adding obinutuzumab to standard of care with a fairly rapid steroid taper down to 7.5 milligrams in 12 weeks and 5 milligrams in 24 weeks led to significantly better complete renal response in those on obinutuzumab. And looking at complement levels, double-stranded DNA, there is definitely in favor of obinutuzumab. What is also important is that unlike in Luna, which gave 4 doses, 2 in the beginning, 2 at 6 months, they dosed up to a year and looked at outcomes at 7 to 6 weeks. So gave it that really good period of time to show efficacy. And what it showed was that profound B-cell depletion up to 76 weeks. And so what we know about obinutuzumab is it gets deeper and more sustained B-cell depletion, both peripheral bloods as well as tissue, which is not, you cannot measure. But there is, of course, higher adverse events. There is more infusion-related reactions, cytopenias, and hypogammaglobulinemia, which can be a problem. And as I mentioned, there's more tissue-based cell depletion. And the repopulation is also more delayed. Of course, it's not affordable. I looked on Google. If you want to get the Indian-made rituximab or obinutuzumab, it can be something like 400,000 Indian rupees. So it's beyond the means of 99.9% of Sri Lankans. So is there an emerging role of rituximab? One thing I've noticed, rituximab, I use it a lot. I use it in vasculitis, I use it in lupus. A lot of my colleagues who do the podocyte clinics use it in minimal change. Older you are, you don't repopulate that easily. I have patients, 70-year-olds with vasculitis who has had rituximab. 3 years down the line, they still B-cell deplete. But younger you are, you repopulate quite fast. Your young lupus, because we monitor B cells, sometimes they repopulate at 4 months. If you have impaired renal function, you don't repopulate. And obviously, underlying disease, so ANCA repopulation is much slower than with lupus or minimal change. So my proposal is, yes, use rituximab from the outset, but if you can, and I don't know the answer to this, perhaps I should have asked my friend Chanaka before this, but they monitor B-cell subsets. Because by monitoring B-cell subsets, you probably should be redosing it at least every 6 months or even sooner. So is there rituximab? Yes, because it's actually relatively affordable compared to many of the other newer agents. And you can cover many areas. So a lot of our patients with lupus want to get pregnant. Preconception counseling, you can prescribe rituximab up to the 2nd trimester. It is very effective for skin and joint. It certainly will reduce steroid burden if you use it like you would use a CNI and rapid steroid taper, as was also in the Regency trial, and clearly it works in those who are non-adherent. So we use rituximab quite a lot, especially in the non-adherent group, to get some level of control. So the summary treatment algorithm is, yes, methylprednisolone, 2 to 3 doses. Most of the trials did say 2 doses. Oral pred, but a rapid taper. Remember, we have a responsibility by our patients and not leave them on steroids and let them get all the other complications. And the way I do it, and I learned this when I started using the rapid taper or the Pexivas protocol for vasculitis, is to give a date and tell this is the dose you got to be on at that date. Factoring in the fact that some of our patients have limited health literacy, they may not be able to count. They may not be able, so you need to factor all that in understanding. And hydroxychloroquine, and you either give MMF plus a CNI or MMF plus rituximab. We are fans. I have been a massive fan of protocol biopsies, and I would protocol biopsy at a year with the aim to then stopping steroids. You need to redose rituximab and base that on CD19 levels, not just the percentage CD19, but also the CD19 absolute levels. And consider IV cyclophosphamide for resistant disease, and that should become apparent within 6 months to a year based on renal function, proteinuria, and urinary sediment. So what about belimumab? I again appreciate this is a slide that is more relevant where belimumab is available. Belimumab has been shown to increase the percentage of complete renal response, and it is in many trials being used as first line. It was in EULA, it's also in ACR, but we in London, Barts, and especially also, I don't think in most other units I've spoken to do not use belimumab as first line for a variety of reasons, partly the cost, and secondly, that it is mostly given as intravenous once a month, and there's a huge resource pressure. But we did use it, and we recently published that in Lupus. So we tended to use it for people with lower GFRs. There were more Black patients. There was a higher SLEDAI score of 16 versus 12, and it was almost a 2nd and 3rd line regimen. And what is not said here, because it's really difficult to be certain about, is a lot of these patients are non-adherent, and they don't tell you They lie to your face so much that it is really hard to assess that. And what we did find was just by adding a biologic that we can give once a month, you get significant improvement in their SLEDAI score, their dsDNAs, their complements, etc. However, it's costly, and I appreciate, but it's coming close to losing its patent, but it will come available. Another thing that we do, there is a study, the BEAT study, which showed using belimumab after rituximab in all comers of lupus, not just lupus nephritis, and that's shown that, and anecdotally, we also see that people who have had rituximab previously tend to respond better with belimumab. So when to wean immunosuppression? So I came from an era where we never weaned immunosuppression as a trainee registrar. Then I went through a phase of weaning immunosuppression, and now we've gone back to not weaning immunosuppression. Partly because the studies are showing if you stop all immunosuppression, they will relapse. And lupus is not an easy disease to manage, and you really don't want relapses. So what I look at is I look at original disease, I look at response, I look at the chronicity, the proteinuria, as well as the protocol biopsy, and then I will try to bring them off steroids, but I leave them on MMF and hydroxychloroquine, and so far I avoid stopping either of the two. Lupus, like vasculitis, like any other disease, has other impact of the medications we give you them, as well as if you're managing a chronic disease. So you've got to manage the proteinuria despite optimal treatment. So A's and ARBs are pretty standard. Blood pressure target should be less than 130 or 80, and we are now started to use SGLT2 inhibitors despite DAPA-CKD, EMPA-CKD, one of the exclusion criteria being immunosuppression. Why? Because it's our transplant colleagues, I for a while used to do a diabetes transplant clinic with my diabetologist. I've not stopped doing that now, but we started prescribing SGLT2s there, and increasingly there's a lot of experience showing that it's safe. Do we know whether it's going to be effective long-term? That data, I have not seen any data supporting that as yet. Retinal screening is really important. Every 5 years, our patients on hydroxychloroquine should have their retina screened. And again, managing their overall risk factors, cardiovascular risk factors, are paramount to provide optimal care for a long-standing condition. What's on the horizon? So I've talked about rituximab, belimumab. They are already there for ages. Anifrolumab has got phase 3 data. We don't use it. It's not NICE approved. I have no experience of using it. And there is, of course, JAK inhibitors, tyrosine kinase inhibitors. There's fusion proteins coming up. This Chinese product, telitacicept. There is some phase 2 data come out that's shown to be promising in the future. None of these are going to be cheap. What's also very exciting is CAR T therapy. So I was at EULA a few months ago in Barcelona. There were like literally presentation where the technology is getting better and better. Looking at it, where the key problems that what worries me is the cytokine release syndrome and neurotoxicity, and the technology has moved to such a level where you can do CAR T therapy as a day case. And there are also other bispecific antibodies looking at multiple targets, which are already used in cancer, are being now trialed in lupus in phase 1 and 2 studies. So as I mentioned, vasculitis is easy to manage. I have a clinic solely doing vasculitis, but lupus is really hard. And the reason is that our patients are young, they have chaotic lives, often they're very poor, and they're single parents often, and they don't like taking their medicines. So doing it as a team is really important, including a dermatologist. We do a lupus telederm and CNSs, and working in a single setting, which is what I do, works. And we don't only socialize at work, We socialize outside because we're building those relationships. And I tell all your young doctors, build a team because that's good for your patients. Thank you very much.
Thank you very much, Dr. Ravi Rajakariar, for that very illuminating lecture. Next, we have Professor Andrew Davenport. He's a big name in dialysis, I know, from UK. He's a professor of dialysis and ICU nephrology at the UCL Center for Kidney and Bladder Health, Royal Free Hospital, University College London. An internationally recognized expert on dialysis and critical care nephrology. He has made a significant contribution to advancing renal replacement therapy, dialysis standards, and renal nutrition. Now, he has served as president of many societies. If I go to talk about each of these, it will take his time away. Through his leadership, research, and clinical expertise, Professor Davenport continues to play a pivotal role in global nephrology, improving outcomes for patients with kidney disease. So, topic that he has chosen for today is hepatorenal syndrome. So, over to you, sir.
Thank you very much for that very kind introduction. So today I'm really going to talk about acute kidney injury in patients with chronic liver disease. And for this talk, I have no conflicts of interest. If you look at what the data in England, you can see that over time, over the last 10 years, the number of hospital admissions for both men and women has steadily increased. There's a slight dip during COVID, but otherwise, as you can see, it's now picked back up. And similarly, if you look at the deaths from liver disease in England, again, you can see a steady rise over the last 10 years or so. So it's becoming a bigger problem in the UK. Just over 10 years ago, we first sat down with the International Club of Ascites to try and agree definitions in terms of what is acute kidney injury in patients with chronic liver disease, the so-called HRS type 1. And as you can see, we now have an agreed definition between liver doctors and kidney doctors. So very simplistically, it's a simple rise in serum creatinine of 0.3 milligrams per deciliter or greater within a 48-hour period, or a 1.5 to 1.9 times increase within 7 days of a baseline creatinine. And for the liver team, that could be a creatinine within the last 3 months, or using admission creatinine. Or equally, as many liver patients have reduced urine output, a urine output of less than 0.5 mils per kilo per hour for more than 6 hours. And then stage 2, a 2 to 2.9 times increase, and stage 3, a 3 times or greater increase, or greater than 4, or start of renal replacement therapy. But obviously the patients have to have decompensated cirrhosis. At the time we're making the diagnosis, no evidence of shock, no treatment, current treatment with nephrotoxic medicines, and no response to volume expansion. Technically, there should be absence of parenchymal disease, but as you're probably aware, that we're now treating more patients with diabetes, more patients with hypertension, and so actually, we may now see levels of proteinuria greater than 0.5 grams per day due to underlying parenchymal disease due to diabetes or hypertension, etc., but less than 50 red blood cells. And there should be a vasomotor component, and that means that the urine sodium should be very low, so the fractional excretion of sodium should be about 0.2% or less. So what we're looking at is a definition of AKI based on changes in serum creatinine. So the question is, well, what's the problem? I mean, we all know what creatinine is. We measure it. We see it as results every day. But creatinine comes from creatine. And creatine, it requires just 3 amino acids. And the first of the synthesis steps of creatine is in the kidney, and then subsequently in the liver. So if a patient has chronic liver disease, they may not be able to convert these amino acids into creatinine. So the production rate goes down, and that's important. And the other issue is that the conversion of creatine to creatinine takes place in muscle. And many patients with chronic liver disease have a degree of sarcopenia, loss of muscle mass, and are not physically active. And therefore, the generation of creatine and then the generation of creatinine is slower in patients with chronic liver disease. So if you look at this picture here, this is looking at generation rates of creatinine. And so if we were to look at, whoops, I've just gone back 2 slides. Oops, I need to go back. Sorry about this, team. Let's go forward. Can we go back? Yes, we can go back. So if we think, gosh, having problems here. Can I go back on this one? Is that back? Yeah, it should be back. I apologize for this. So, right. So if we look at this slide, if you imagine, if we have somebody who is producing a lot of creatinine, 20 milligrams per kilogram per day, to go from a creatinine of 1 to 2, to double it, as you can see, it takes about 12 hours. To go from 1 to 3 takes just about 30 hours. But if somebody has a very slow rate of creatinine production, 5 milligrams per kilogram per day, you can see here, if we double it from 1 to 2, you can see it's going to take about over 2 days. And actually, you can see that after 4 days, it's not gone up to 3. So one of the issues is that when we're looking after patients with chronic liver disease, we often look at the creatinine, and we often say, oh yes, it's gone up a little bit every day. And so we don't quite realize actually that the kidney is getting worse quite significantly day by day. And that's a real problem. And the other issue, of course, is the laboratory measurement. So a lot of laboratories still use a color-based assay, a Jaffe type assay. And bilirubin is a color. And so as bilirubin levels rise, it interferes with the colorimetric Jaffe type assay and therefore underestimates the true creatinine. And even if we switch to enzymatic assays, at very high creatinine levels, there still can be interference with the assay. And so some years ago, Andy Burrows made us perform lots of isotope GFR measurements in our liver failure patients. And here we're using what's called an IDMS GFR. So this is when your laboratory corrects the creatinine measurement for an isotope dilution creatinine. And what you can see here is that it doesn't matter whether we've used a Cockcroft-Gault equation, which is the top left, or we've used the MDRD4 or MDRD5 equations. You can see that when we use creatinine, it underestimates the true kidney function all the time. And so you could argue, well, okay, if creatinine's not so good, why don't we use cystatin C? So here's a study from Europe. This is very similar to our own internal data. On the 2 panels on the right is when you're looking at creatinine measurements of kidney function. Inulin is giving you a true GFR. And as you can see how creatinine measurements overestimate true kidney function. The 2 in between, Hook and Larson, are 2 of the equations used for checking GFR with cystatin C. And so you could argue they're slightly better than creatinine, but they still overestimate true kidney function. And the other issue with cystatin C is that if there's inflammation, then cystatin C production is increased. So if you go from Child-Pugh A to B to C, cystatin C levels naturally rise. So there's confounding with cystatin C. So it's unfortunately just as bad as creatinine. And the other problem with both of these, whether it's creatinine or cystatin C, they're concentrations. And so if we have a patient with lots of ascites, there's extra fluid. So it dilutes down the cystatin C or the creatinine. So if you look at the simple graph over here, what you notice is as the patients have more ascites, the difference in terms of GFR measured with creatinine compared to the isotope gets larger. So there's a dilution effect. So some years ago, we sat down, or Andy Burrows sat people down, to try and work out if we could come up with an equation to try and work out what is the true GFR in these patients. And so the Royal Free published the Royal Free equation, which is this one on the top, which uses creatinine, urea, the INR, and the age of the patient. And some colleagues of ours in California, in Los Angeles, came up with their own equation, which they used really around the time of liver transplantation. And both of these equations are freely available on the web. You can just put the numbers in, and at least it gives you a real idea of actually what the real creatinine or GFR is in these patients. And that's really important to understand. So if we go back to AKA HRS, so what we're saying here is that what we assume is that as the liver deteriorates, the pressure inside the liver rises, this intrahepatic resistance increases the pressure in the portal system. There is lots of nitric oxide and the vasodilators in the splanchnic circuit. And eventually the system is these spill over into the systemic circulation. This causes relative hypovolemia. The heart responds by increasing the cardiac output. But unfortunately, the cardiac output doesn't match the drop in systemic vascular resistance. And therefore, these patients are relatively hypovolemic. And this then leads to increased sympathetic nervous system activation, increased noradrenaline production, increased vasopressin, increased angiotensin, etc. And this then leads to the kidney retaining both sodium and water. But if we look at what we're actually seeing now in our patients with AKI, this is European data, and it's very similar to our own. So in their data, you can see just about 44% of patients with AKI actually were pre-renal and generally were volume responsive with a low urinary sodium excretion. About 34% had what we would traditionally call acute tubular necrosis or ischemic injury to the kidney. About 34%. But if you see, the mortality here is over 50%. And typically, the fractional excretion should be greater than 2 to 3%, but I'll show you some data later that contradicts that. And hepatorenal syndrome, only about 12%. And our own series, it's about down to about 10% now. But again, a very high mortality, almost 50%. And technically, these patients shouldn't have shock. Their urine should be relatively bland. And really, it's a diagnosis of excluding pre-renal or ATN. Occasionally, we'll see a patient with post-renal obstruction, and occasionally, again, a patient with glomerular disease. And I've certainly seen patients with IgA nephropathy where we've got red cells that have actually blocked the tubules and have caused acute kidney injury. So it is possible for an acute glomerulonephritis, a flare of IgA, to cause it, and patients underlying chronic liver disease. But what we are seeing more and more is this concept of ACLF, or acute on chronic liver failure. And it's whereby somebody with chronic liver disease, compensated cirrhosis or decompensated cirrhosis, there is a precipitant effect, whether it be an infection, drugs, alcohol, etc., ischemia, surgery, sepsis, etc. And suddenly the patient develops hepatic and other organ complications. And so just as you would have in the intensive care unit, you'd have a SOFA score or an Apache 2 score, or Apache 3 score rather. If a liver disease, we now have a CLIF, the European Organ Score. And it's essentially, if you score 3, that means the organ has failed. So for liver, for example, it'd be a bilirubin over 12 milligrams per deciliter. For the kidney, it'd be a creatinine greater than 3.5 or starting renal replacement therapy. Encephalopathy, grades 3 or 4. An INR of greater than or equal to 2.5, needing vasopressors for circulation. And obviously, if you've got poor respiratory function. So you can add these together to get an organ severity. And the reason for this, of course, is that if patients develop for more organ scores, then the risk of mortality really increases. But interestingly, the one thing that really pushes patients from what we call no ACLF to ACLF grade 1 is renal failure. And renal failure is the major driver behind actually the severity of ACLF. And if we look at what happens to patients who come into hospital with decompensated cirrhosis and ACLF, if they have just liver failure, they actually have a very good survival. But actually, if they have ACLF grade 1 or greater than 1, then I'm afraid to say the survival is down to around about 50%. And interesting, the mortality is actually very quick. It's usually within the first 10 days that the patient dies. So we do have additional issues in terms of how to try and manage these patients. But if we go back to HRS, AKI, how can we try and decide whether patients are hypovolemic or have HRS or have tubular injury? How can we try and clinically decide? Well, first of all, by any clinician, we'll take a history to see if there's any precipitating event, and then examine the patient. So patients with liver disease should be vasodilated. They should have warm hands. So if you simply just feel the hand of a patient, it's cold, you know they are volume deplete. The blood pressure is difficult to interpret because often with the vasodilatation, the blood pressures are systolics of 90, 95, 100, etc. The JVP is difficult to interpret because these patients have a hyperdynamic circulation. So a normal JVP does not mean the patient is not volume deplete. In fact, it's probably best to say that if you can't see the JVP, you know they are volume deplete. So the JVP may well be normal, but the patient is still relatively underfilled. And you can look at things like finger oxygen saturation. But today, what can we do in terms of trying to volume assess patients? Well, traditionally, we could sort of lift the legs up in the air and see what happened to the change in systolic blood pressure to diastolic blood pressure, the so-called pulse pressure. We could see what happens to pulse pressure with a bolus of fluid, etc. But today, of course, we have point-of-care ultrasound, so we can come along with a portable ultrasound machine, look at the inferior vena cava width, get the patient to take some big breaths in and out. If the IVC doesn't change, they're obviously severely hypovolemic. If it totally collapses, they're severely hypovolemic. And so we're looking at, do they have a collapse of more than 50%? Is what we're looking for, is the space to give them some fluid. And the other issue, of course, is to look at what happens to velocity in terms of the VTI. We can do this in terms of IVC, look at the velocity index in terms of what happens when we give them some fluid with the IVC, or similarly look at the cardiac output in terms of what happens in terms of flow out of the aorta during one cardiac cycle. So there are ways of now trying to better assess patients as to whether they're going to respond to fluids. So the next question, of course, is what about biomarkers? Well, the biomarker that's been most extensively looked at is obviously NGAL. As you can see here on the right, in terms of serum NGAL, there's no real help in terms of differentiating whether it's pre-renal, established kidney disease, ATN, or HRS. And actually, when it comes to NGAL in the urine, oops, keep pressing the wrong button here, what you can see in terms of the NGAL in the urine is that it's actually it's highest. It is. It's actually highest with ATN, is much higher than HRS, etc. So not particularly helpful. What we do know is that classically in HRS, the fractional excretion of sodium will be much lower compared to ATN or pre-renal. So if you're not giving diuretics, then a fractional excretion of sodium is actually quite useful. As you can see in terms of urine albumin, you can see it progressively increases from pre-renal to HRS to acute tubular injury. And if you look in terms of other biomarkers, then generally they're not particularly helpful. Although there may be some like KIM1 and IL-18, which are much more likely to be raised with acute tumoral ischemia, if you look at the area under the curve for diagnostic accuracy, they're not very helpful. So biomarkers, I'm afraid, have not been helpful to try and differentiate HRS-AKI from other forms of acute kidney injury. So what are predictive factors? Well, if the patient's recently had systemic inflammation, if they've recently had some sort of acute hemodynamic changes, recently been treated with spontaneous bacterial peritonitis or other systemic infections, if they had a large volume paracentesis without albumin, or in the very early stages of ACLF. And so what's the European management? So the first question in Europe is, what are you going to do if the patient doesn't respond? And that's a big question, because the question is, are we going to be active with this patient, or are we going to have a more sort of end-of-life type management of the patient? That's a big issue in terms of whether we take this patient on for treatment. If we are going to treat them, then we're going to give terlipressin a milligram 4 to 6 hourly, or if you give it an infusion as a constant infusion at just 2 milligrams per day, and that obviously gives the patient a lower dose and less side effects. If the creatinine doesn't fall by 25% within 2 days, steadily increase the dose every couple of days up to a maximum of 12 milligrams. And at the same time, we're giving patients large volumes of albumin. Europeans, the complete response is a serum creatinine that goes back down to the baseline within 0.3 milligrams per deciliter of the initial baseline. And a partial decrease would be the creatinine goes down, but not low enough. And what happens if they recur after we've completed the treatment course? The European advice is to retreat. The US is slightly different. So the FDA have slightly different criteria, give us a slightly different dose of terlipressin, 0.85 milligrams every 6 hours, 1 to 2 days. Here, if it's 30%, less than a 30% fall in serum creatinine, then to double the dose to 1.7 milligrams. If obviously there's greater than 30% fall, just continue, and a maximum of 14 days. And they define response differently. Again, there's a serum creatinine of less than 1.5 milligrams per deciliter on 2 consecutive days. Obviously, the problem with terlipressin is it's a potent vasoconstrictor. So you can't give it to somebody who's had a recent MI, got peripheral ischemia, recent stroke, etc. We're going to monitor the blood pressure, serum creatinine, and respiratory function. Because don't forget, you're giving patients albumin at the same time. So albumin has a sodium load, it has a colloid load, and it's very possible that patients develop pulmonary edema. So it's really important to monitor respiratory function. And again, if you look at the actual survival and what happens to patients with HRS in the clinical trials, these are some of the larger trials, what you notice is that actually success is only around about 30% at most. And most of the time, in terms of side effects and people having to stop terlipressin, usually it's around about sort of 6%. But there was one trial where it was about 20%. But in that trial, they were giving terlipressin and albumin to patients with serum creatinines greater than 3 milligrams per deciliter and really were having problems with respiratory control. So, will the patient respond to terlipressin? Obviously, if they've got ATN, they're not going to respond very well at all. If there's been no volume expansion with albumin, they're less likely. The higher the creatinine that you start with, the less they're likely to sustain an improvement. Again, higher bilirubin, certainly once you go above 10 milligrams per deciliter, less likely to respond. If the blood pressure doesn't go up by more than 5 milligrams in the first 2 days, they're less likely to respond. And again, if they've got a higher grade of ACLF, they're less likely to respond. But one of the issues is this. Although we always think of HRS as a vasomotor condition, this is staining, this is biopsy we've taken with capsase-3. So this is looking at cells which are programmed to die. Now, obviously, as you can see over here with ATN, you can see the staining for capsase-3. But actually, this is HRS, and there is some slight staining with HRS. So HRS is more than just vasomotor. And this is now looking at toll-like 2 and 4 receptor staining. And again, you can see inflammation with upregulation of TL4 and also TL2 in ATN. But there's also staining with HRS. So there is more than just vasomotor. So there is ischemia going on and causing inflammation in the kidney in HRS. And that's one of the issues, that if you leave these patients too long, whilst you just watch the creatinine go up little bit by little bit, you're going to be less likely to get a response. And this is one of the issues with HRS. So let me try and summarize. Renal dysfunction increases with advancing stages of chronic liver disease and acute on chronic liver failure. Certainly with HRS, we think it's a relative renal hypoperfusion with a reduced effective circulating volume. There certainly is increased renal vasoconstriction, driven predominantly by sympathetic nervous system and local renal vasoconstrictors. But there's an inflammatory component, and we're unsure at the moment as whether this is endotoxin driven or whether it's just simply driven by ischemia. The other issue, of course, is that we always get asked is what to do about the ascites. So if the ascites is very severe and it is obviously causing the patient great discomfort, then yes, please tap it. And there's a difference between what I call acute rise in intra-abdominal pressure versus chronic. And so if the abdominal has been large for some time and the pressure is not changing, then we'd leave it well alone. But certainly if the patient is in discomfort, then we advise you to tap the ascites. So, it's common, renal dysfunction in patients with cirrhosis. It's associated with a poor prognosis. The key message really is that serum creatinine and changes in serum creatinine really underestimate the real changes in renal function. And classical HRS, AKI, is pathophysiologically and clinically distinct from renal dysfunction in ACLF. But many patients now have AKI in the setting of ACLF. And I'd just like to end by thanking all my colleagues I've worked with at the Royal Free and UCL over the many years in terms of treating patients with chronic liver disease and acute kidney injury. And it's a long, tough road, and thank you.
Thank you very much, Professor Davenport, for that very interesting lecture. May I invite all three speakers to the stage and also the panelists, Dr. Udana Ratnapala, Dr. Anura Hewageegana, Dr. Nishantha Nanayakkara, and Dr. Dilukshi Pilapitiya. Start the discussion.
I'll ask the audience also to participate and you can start the discussion. You can also have questions from the panelists to the speakers. Shall we start the discussion? Yep.
Yeah, Anura, you would like to give some comments and start on the discussion.
Yeah, I have a comment and a question from Ravi based on your presentation regarding the place of rituximab that you have given in your treatment algorithm. Now, having said that, the LUNA 2012 has failed to show that rituximab outperforms, and the guidelines ASIA, EULA, KDIGO has not placed Ritux in the induction regime. We still consider that as a rescue therapy, and what made you think that that you have promoted it up in the scale, up to a, not up to, say, not a rescue therapy, up to an induction regime? Any basis for that? Can you just...
So I basically, I think it's partly influenced by obinutuzumab. And the reality being that, so if you have a patient who is literate and is willing to take medications and has got preserved renal function, and you can be confident they will take, then I would go with a CNI and MMF with a more rapid taper of steroids. But then if you have a patient that your hunch is they're not going to take medicines, then rituximab might be a reasonable option, or IV cyclophosphamide. So that's where I'm coming from. And I do think that, I think when we use rituximab, it is more effective than the LUNA or Explorer suggested. So I think that's where obinutuzumab has empowered me to use rituximab more now. But it is controversial. It's not based on guidelines.
Yeah, my question goes to Professor Patel regarding vasculitis. We being a resource-poor setting, we don't have anti-MPO antibodies or anti-PR3 antibodies, at large. How will it affect our management for diagnosis in the first place, and the management and the follow-up of our patients? How will it affect? How do you see we managing vasculitis patients without anti-PR3 and anti-MPO? Can you imagine?
Wow. You always kind of think it's hard, even when you have all the investigations, let alone when you don't have them. So I guess clinical acumen, going back to basics, is really important. And many times you just get a hunch, isn't it, that this isn't going right. So in addition to the clinical history examination, you've got inflammatory markers, at least anyway. I guess that's the start. And then imaging, whatever you have, is kind of good to kind of do. And then access to biopsy. I don't know, again, how easy that is. Of course, managing sort of the risk versus the benefits of doing a biopsy. But I think then it'll probably be an even lower threshold if you don't have immunological markers. So it's hard, isn't it? I can't even imagine, because we always moan that, people are not doing the immunological tests early enough. But if you don't have them at all, I'm sure that's really hard. So I guess clinical acumen and the other investigations that you have, and then probably a bit more higher reliance on the biopsies. In lupus, I would biopsy very early. In vasculitis, I guess sometimes if it's very non-specific, I wouldn't biopsy so early, but then PET scans and other radiological imaging may be the way forwards as well.
Stopping treatment without these anti-MPO and anti-PR3, because the current recommendation is stop at 2 to 3 years. But we don't know where we are.
It's really hard. And I think I agree with you when you said about there's been a big move. So when I was a trainee, nobody stopped any immunosuppression, and my consultants would probably shout at me even if I started reducing too quickly. And then we went through a phase of stopping, but then there's the risk of relapses are so high, and the patients would probably prefer to take low dose of something rather than nothing. So I think that seems to be, again, we've gone back in a little circle, but of course managing the risks around the immunosuppression. So steroid reduction definitely earlier, much earlier than what I perhaps was taught to do years ago, and then sort of smaller doses of the maintenance treatment to continue if you don't have other markers to go with.
Do you have anything to say?
No, I don't.
A question for Prof. Davenport. So in Sri Lankan setting, I think managing HR is quite tricky, because sometimes in certain settings we probably don't have IV albumin and keep aside IV terlipressin. So the quickest option would be just to maintain the mean arterial pressure with noradrenaline and then to continue a fine fluid balance kind of thing. But probably some settings do have IV albumin and combine it with IV noradrenaline. What do you think of any thoughts, any comments on the practice that we do?
Thanks. So certainly looking at reports from the South Asian continent, then there are successful studies using noradrenaline. But in most centres, probably patients who are on noradrenaline have to be transferred to the intensive care unit rather than being managed on the ward. So the one advantage of terlipressin is it can be a ward-based treatment rather than requiring intensive care support. The other issue, though, is, as you say, is the colloid. And so the issues there are in terms of trying to maintain a circulation. So questions would, one, be what's the hemoglobin? Is there a space to improve the hematocrit? That'd be question one. And then the other issue is what other possible colloids can be used? Now, the problem there is that unfortunately quite a lot of the other current colloids which are available actually do have a potential for causing acute kidney injury. So that is a real problem. But I accept that if you just pour normal saline into a patient, they will become incredibly volume overloaded. And I say the real issue that the Americans ran into in their large trial was respiratory failure. If you're giving colloid and sodium to patients with, say, creatinine of over 3, not surprisingly, they're going to go into pulmonary edema. So that's a real issue, and balancing books. But the point I would make is this. If you start early in terms of treating with terlipressin, you're much more likely to get a response. And I say, we often get fooled by the fact that the creatinine seems to be relatively low, and it only goes up a little bit. Then we sit on the fence and we say, oh yeah, well, we'll see what it's like tomorrow. It might turn the corner by tomorrow. It's only gone up by 0.1. That could be a laboratory error, 0.1 or something. And that's the problem. It's the delay in the treatment. But again, certainly in the UK, we work in the Liver Transplant Centre for North London. Is this patient suitable for transplantation? What's going to happen if they don't get better? And that's a big issue as to whether we should have a more palliative approach. And that's a really big decision that we have to make in terms of with the patient, possibly with the family, etc. And that's a big decision as where to go with the patient.
Yeah, my question goes to Ravi. So excellent talk. And we achieve the remission in lupus and we try to maintain it with azathioprine, which is a sort of useful drug in pregnancy. But I didn't see azathioprine in your sort of presentation. Is there any particular reason? Or
the maintain, I think the maintain trial showed that MMF was superior. So we tend to still leave them on a gram, but then I would reduce it to 500 milligrams BD and live. So that is still thought to be superior to azathioprine. But of course, a lot of our patients want to start families. So you may make the call after a year to switch them with the express view that they will want to start a family. So I think azathioprine is a reasonable option, especially for women of childbearing age who plan to have children, but MMF is thought to be superior. And that's based on the evidence.
We have few minutes for the audience if you have any questions to the panel or the speakers.
My question is for the second speaker. This is regarding the lupus nephritis. We have been using cyclophosphamide several years ago and it's worked well. And now mycophenolate is coming new. It's not working well. So is there a chance of Asians and Africans getting less effective in mycophenolate? And is there evidence for that?
I am not aware of any evidence of a racial bias favors cyclophosphamide over mycophenolate. And again, it comes down to adherence. So if cyclophosphamide, you're giving it intravenously 6 doses, whereas mycophenolate is oral. It's also probably more expensive, am I right, compared to...
It's available in the government sector.
Yeah.
Sir.
So I suppose that's a cost effect as well.
It's available in the government sector now.
Pardon?
In the government sector in Sri Lanka, it's available.
Yeah. But the key thing is around adherence, because the data shows that they are equivalent with the Ginsler paper. But I'd say cyclophosphamide is a very effective drug, because active lupus means the chance of pregnancy is remote, and there's good data that the 3 grams doesn't cause infertility.
But Ravi, I think in arms, they have shown that my MMF is non-inferior, and at the same time, in the Asian cohort, cyclophosphamide has an equal efficacy or even better efficacy.
So as I said, cyclophosphamide works, and we've never had a treatment failure with cyclophosphamide.
As we are waiting for the questions, from the tertiary centers, we see patients awaiting liver transplant. So, Professor Davenport, this is the main question. They send us with a creatinine which changes from month to month, and as nephrology, we have to give the clearance to go ahead for a liver transplant and not for a kind of simultaneous liver-kidney transplant. So, how do we look into it? Which eGFR calculation should we go with? Cockcroft-Gault, MDRD, CKDAP 2021, your one which we have never used so far, to be frank with you. Sorry.
Well, I think, right, there are two issues here. There are differences in terms of the concept of transplantation between, say, Europe and the US. And that comes down to money. So the transplant team in the US get far more money for doing combined liver and kidney transplant than if they do a single kidney and a single liver. So that's a big difference. So certainly in the UK and other parts of Europe, we're more likely to do a liver transplant and then possibly then do a second kidney transplant. And one of the reasons for that is that often during liver transplantation, the blood pressure goes down low. And so often what we found is that if patients have been run with systolics of around about 100, the kidney transplant never works. So we found that to be relatively futile. So the issues for us are, we would do one of two things. One, do we want to biopsy the kidney? That's question one, to see how much, if you imagine fibrosis there is there, chronic damage, because that would be a big issue in terms of counselling the patient. Yes, you can have a liver transplant, but you're going to need a kidney transplant, well, dialysis and then a kidney transplant sometime. As a rule of thumb, we reckon you lose probably about 30% of kidney function with a liver transplant. Roughly that amount is what you'll lose, to be honest.
And the GFR calculation, what you recommend?
Well, I'm afraid to say I have to be biased, and we use the Royal-Free equation.
Right, thank you very much.
Thank you.
We have come to the end of this symposium. Once again, shall we thank, on behalf of the College of Physicians, I will thank all three speakers and the panelists. Shall we show our appreciation in the usual way? And can I call upon the speakers to accept the token of appreciation from Professor Sharif? Yes. Dr. Patel. Professor Patel.
Professor Mumtaz Patel, please. I'm sorry I can't come to you for obvious reasons.
Could I now please invite Dr. Praveen Veeratunga to award certificates and letters of appreciation to our chairpersons?